Okay, we'll go ahead and get started. I'm sure some people will start to trickle in, which is totally fine. But thank you everyone for coming to the meeting. Thanks for some of you coming on your lunch break or coming in the middle of the workday. Today we have a very special guest, Dr. Curtis, and he's going to spend some time talking to us about ADHD in primary care, which I know at least at my clinic we see a lot of, and so really any information and guidance is going to be super helpful. As far as announcements, there's not too many. If anyone has any job postings or opportunities, anything like that, feel free to share them in the chat. If you're looking for it, you can always go to the CFHA website where we have job postings. And really anything related to that, we're more than happy to share in this time and with each other. One fun announcement that we have is that Doctors Robinson and Ryder recently published their third edition of Behavioral Consultation in Primary Care. And they shared with us a coupon that if you would like to purchase it, you can get 20% off by using the code SPRAUT. And you can scan that QR code and it takes you to the website where you can purchase it. So that's really exciting and really cool that they thought to share that with us. I'll give everyone a second. If you would like to scan that, you can go ahead and scan that. Okay. I think that's all of course, we still have our mentor program going. Our early career representative, Ryan, is very helpful in making those matches. And so if you are looking to mentor or looking for a mentor, feel free to scan those QR codes as well. And we can put those up again at the end too. But any questions or anything before we start?
Yes, promo code slide.
Oh, perfect. Yes, thank you, Hannah.
Just zoom in on that QR code.
And I can also, as we get the meeting going, I can put the link and the code in the chat too for people. I'm happy to do that. Wonderful. Okay, Dr. Curtis, the floor is yours, and we are happy to listen and learn and take in the wisdom that you have to offer. So thank you for being here.
My pleasure. I'm excited to visit with you guys. Let me just see if I can get to share screen, get over the first hump here. We should be good. Also, while I'm doing that, let me just say that I'm happy if people want to unmute and interrupt, ask questions along the way. This is great to be able to share information, but it's also great to be able to drill down and discuss when we need to. Wow, you'd think after COVID, I would know exactly everything on this.
Down in the bottom toolbar, kind of in the middle, there should be a green button
Ah,
with an arrow in it. That's the share button.
there we go. Thank you. Okay. You should be seeing a screen that says attention deficit hyperactivity disorder with my name on it.
It doesn't look like it quite pulled up yet.
Okay. Let's see.
Make sure, yeah, there we go. Let's
There
see.
you go.
Yep.
There we go. Perfect.
ADHD, like a red slideshow, red and white.
Yep, we're good. All right. Let's see if I can make this guy. All right. Wonderful. It's funny because I was going through this with the assumption that we'd be, really focusing on pediatrics. But I know more and more you're going to have a lot of people coming into primary care behavioral health with questions of, I think I have ADHD as a young adult or as even a older adult. So we'll touch on that a little bit, but this is really going to be focusing more on children and adolescents presenting ADHD related concerns. So, all right, I'm going to skip this because I think on the virtual format, it doesn't work too well. But there's a great, if you ever watch Modern Family, great part where they're talking about Luke having ADHD, and then they go on and show how Phil is doing 19 different things at the same time and falling all over himself. So if you get a chance to YouTube that one, it's really good. But really want to go over the functional deficits associated with ADHD. What are some of the best practices that we know for psychosocial and pharmacological interventions? I want you to be familiar with some of the medications that are commonly prescribed for ADHD, and then being able to apply this within a PCBH framework to work with families. ADHD intervention is almost always conducted on an outpatient structured basis. And there are a lot of these things that we can easily weave into a PCBH workflow. And I found that with my past being a really in-depth focus on disruptive behavior intervention, that has really helped me in PCBH with different kinds of clinical populations across the lifespan, as having that behavioral those behavioral skills to be able to dismantle some of the larger psychological issues being presented, break them down into workable task analyses, and set up reinforcement plans for those. So I think this will not only help with your patients that present with ADHD, but also with others that have other challenging concerns. When we think about ADHD, at its core, it is a disorder of behavioral inhibition. It's thinking about it's not the inability to pay attention. It's the fundamental inability to inhibit those reflex-like responses to stimuli events. Also, the ability to kind of stop an ongoing response or downregulate, as well as to create this little delay between thought and action. More maybe pragmatically, if you think about a kid on the playground that is engaging in something like touch football, and as they get more and more physically stimulated, it escalates to a little rougher play. It turns into tackle, where most kids are going, okay, it's getting a little tense. I need to tamper it down. These kids are like, oh, now we're starting to have fun, and so there's that different self-regulatory metric there that we often encounter. Um, a secondary component really is the executive functioning component. This is difficulties working memory, the ability to organize things that we've done maybe a million and three times, but each time we approach it, it feels like it's new. You'll see individuals with ADHD that have gone through the same kinds of circumstances numerous times, but have failed to generalize an approach strategy for those. Language and affect are important parts of this too. When we look at the symptoms, the core symptoms, the external, there are two domains, primary domains. There's the externalizing domain and the internalizing domain. And within the externalizing presentation, there are subdomains. So we have hyperactivity and impulsivity. And the DSM-5-TR has 9 symptoms listed and not evenly distributed. So from an impulse control standpoint, that a lot of blurting out, interjecting, having a hard time patiently awaiting turns, whereas the hyperactivity is kind of increased gross motor movements, leaving seat, fidgeting, playing, difficulty playing, feeling like they're driven by a motor in many ways. Diagnostically, you need 6 out of 9 of these to qualify for the diagnostic criteria. Same with inattentive symptoms, except for inattentive symptoms are more broadly conceptualized within a single domain for 9 symptoms as well. And a lot of this has to do with kind of being able to exert sustained mental effort. People will say, oh, I had this conversation today, as a matter of fact, a young girl that the parent was like, well, I'm not sure if it's really ADHD, because when I'm one-on-one with her, she can focus for an hour and a half, or when she's on Roblox, she could do that for 4 hours, and it's a different kind of stimulation, but the ability to initiate and proactively assert some level of mental effort towards a task is very different than reacting to visual stimuli like that you see on a video game. Again, 6 out of 9 symptoms needed for a diagnosis. I'm sure you guys are familiar with the diagnostic nomenclature. I only have this up here really for one thing because you can obviously look in your chart and have it populated the ICD codes and things like that. But when it comes to charges, if you have a conceptualization that doesn't quite meet the criteria for hyperactive, impulsive, inattentive, or combined type, a lot of people will make an unspecified diagnosis, and that's seldom reimbursed. It's seldom paid by commercial payers, whereas other ADHD is. So other specified ADHD. And so when you write your conceptualization, just making sure you justify that, doesn't meet the full number of symptoms required. However, the 4 or 5 symptoms that were endorsed are to a level of severity that's significantly impairing across both settings, et cetera. You can make a justification, or this person has other ADHD by function because maybe they don't have the true ADHD in terms of the developmental trajectory, but they've had some life event that's prompted it. For instance, I had a kid with a solid tumor that by all intents and purposes had ADHD, but came about it in a different way and with more specific narrow band of symptoms. So just some things to think about. The 314.8 F90.8 is one that you're more likely to get paid for doing the same work as if you just varied it by that 0.9 modifier. So just be considerate of that. Okay. We know that there's a strong neurological basis for what's going on with the ADHD, largely focused on our prefrontal cortex, the kind of higher order thinking of planning, organization, impulse control. There are some quote unquote preventable risk factors for ADHD. We know that there's a strong association between oxygen deprivation during gestation or delivery. So good prenatal care could prevent these cases in some cases. Exposure to teratogens, if someone's smoking and drinking, they're going to be much more likely during pregnancy to have a child that has these problems later on. Any kind of neurological insult. We often see this in kids who are born early and low birth weight. In a lot of cases, you might have healthy twins, but because they're twins, they might come out a little earlier and smaller, so they might be at greater risk for this. This number is increasing. When you look at the data over years, it seems like when I was in graduate school, it's more like 5 to 7% of kids in our studies, and maybe we're getting better with our studies, but could be our technology. I'm not sure, but there are a lot of things that are just demonstrating an increase in the prevalence of ADHD over time. So CDC and some large national prevalence studies are showing that it's as high as 11% in the general population. We see it more often in boys than girls, especially in clinic settings. Although I've been getting much more of closer equitable mix in the clinic. Why do you guys think that we see it more in boys than girls? Do you think it is a true gender difference? Give my 3-second pause there. I would speculate that some of this is social, and that our expectations for how boys should behave are often different than how we expect girls to behave. The saying "boys will be boys" kind of brings up certain images of behavior. Girls will be girls brings up a very different perspective. I have 3 girls in my house, so that's certainly changed in my life for sure. But nonetheless, I think that our social norms, sometimes we may underdiagnose girls with these conditions. Also, the influence of testosterone may influence a presentation that's more physical or aggressive in its presentation. So that might create more of a squeaky wheel to get a diagnosis. We see it pretty consistently across cultures. We see higher rates of diagnosis in white upper middle class children and higher for much lower income African American children. And I think the social phenomena here is one that for the white upper middle class children are more likely to have insurance and to seek care. So it's partly reflecting a health seeking behavior. And with those in the lower income African American children, I think sometimes are diagnosed based on um, uh, perceived conduct related needs, and sometimes it could even be some institutional bias and racism. So just things to think about, trying to make sure we're using measurement-based care and being really thoughtful about not just what's going on, but why it's taking place. Um, so the current DSM indicates that symptoms need to be present prior to age 12. In reality, I think it's much earlier than that. Previous DSM versions had it at 7. So I think that thinking about onset, maybe that the behaviors were present prior to age 12. They weren't necessarily impairing or to a degree that's a functional intrusion, but ADHD isn't something that emerges in adolescence or in adulthood. It is something that has a developmental course to it. And that's a key element for our assessment, especially when we see folks that are more late adolescents and young adults that are looking for services. Symptoms do not, you don't grow out of ADHD. They're lifelong and persist. I think when people grow out of ADHD, they develop compensatory tools and learn ways to adapt or don't. And if they don't have functional adaptations, and we see higher preponderance of people with ADHD in the justice system. There's a higher percentage of people with ADHD in the justice system, higher rate of ADHD in car accidents, higher rate of ADHD in unprotected sex, and in the adoption pool. So these are all kind of outcomes of difficulties with impulse control. Most children with ADHD have ADHD and nothing winds me up more than clinicians saying, "Oh, it's just a simple case of ADHD." There are very few simple cases of ADHD. It's usually our physician partners that say, "Oh, it's a simple ADHD thing," because they don't ask the questions, the psychosocial questions, and some of the broader spectrum concerns, because they don't have tools for those. They're not going to medicate ODD or conduct related problems. Well, not shouldn't be, but sometimes they do. So it may be simplified by what's exists in their toolbox, and I work with some great pediatricians, but sometimes they just don't necessarily see some of these other things. It's also known that if it's untreated, ADHD can be a huge risk factor for future problems, substance abuse, delinquency. Those with the inattentive type presentation are more likely to experience anxiety and depression in adolescence and adulthood. Those with more hyperactive and impulsive presentations are more at risk for more of the conduct and delinquency oriented, substance use oriented trajectories. And so if you think about ADHD populations in thirds, there's a third that really by adolescence, their externalizing symptoms are less problematic, don't really require a lot of medication support. Another third that really needs support throughout their school years, essentially. And then another third that really needs more support and has more sustained functional impairments even on through adulthood. So most individuals, so 2/3 of those that are treated with medication anyway, don't require medication into adulthood. So a third or less require a medication in adulthood. So this is, if there's anything that you take away from a screening and diagnostic perspective, is that we diagnose ADHD by kind of ruling everything else out, because ADHD presents normal behaviors, just they occur more frequently at greater extremes. When we have someone who's depressed and they come in and they describe their thinking, they'll talk about some catastrophizing or all or nothing thinking patterns. They'll think of things that are distortions, that are alterations of thought. Someone with a psychotic disorder clearly has some problems with reality testing. That's not the case with someone with ADHD. They don't have any abnormal thoughts or behaviors. They just have normal everyday behaviors that occur at an extreme and that are no longer functional. They've become interfering. So it may be that there's 90% of the population should really be, attention vigilant disorder. And if we put this in perspective, that 10% of these folks don't really have a disorder, they're just different from the 90%. And maybe the ones of us that do not have it are just too vigilant. But nonetheless, this is a continuum, and it's a disorder of performance, not ability. So if we had a distribution of people assessed for IQ, you're going to have some on the really smart end of that distribution, some that are on the lower end. It's the same with ADHD. It's evenly distributed across the normal population. So you might have an individual who is the smartest student in the entire school. Their performance might not show it. Some days it might, some days it might not. So it's that variable performance. If there's a kind of hallmark symptom of ADHD is these individuals tend to be consistently inconsistent. They who's going to show up each day varies based on kind of the kind of environmental stimulation and structure. Also, the executive functioning elements are known to present approximately a 30% delay in functioning. So, really 25 to 40% delay in executive functioning. So if you think about a kiddo who's 15, who's now able to, by age, their chronological age to be able to get a driver's permit, and that individual has ADHD, they may have the attention, the planning, the organizational skills that's more commensurate with someone who's 10 or 11. Not intellectually, just the executive functioning pieces of that. So how you would approach navigating driving and monitoring and independence in that realm might be much more hands-on and directive and structured than someone who doesn't have these kinds of impairments. Now, of course, when you get 28, 30 years old, for the executive functioning delay, it sort of evens out to some degree. So in that regard, it's not really growing out of it. It's just the developmental demands are kind of equalized across ages. So when we think about ADHD presenting in the primary care environment, primary care is much faster and looser than an outpatient setting where we're going to have a very lengthy and comprehensive evaluation. The risk is to foreclose too early on a diagnosis and to initiate treatment. And so just being really mindful of considering the exclusionary criteria to be able to move forward with diagnosing. So ADHD symptoms overlap a lot. Someone who's depressed might show poor concentration and attention, some disruptive behavior due to their irritability. Same with anxiety, be distractible, fidgety, inattentive. If someone's having a hard time learning, they're going to be off task. They may not be. They may need more supervision and management in the classroom because they can't engage in the task at hand. Having trauma, certainly present that sense of hypervigilance, and the re-experiencing can really look in many ways like ADHD. I've had a number of kids that have come in, they've had really really tough early lives and experienced abuse and neglect. And the goal is to try and get them on ADHD medication. And when we looked at their history, it didn't line up with ADHD. So making sure that we're not medicating a problem that needs more specific attention. Adjustment. I had one of my early evaluations when I was a graduate student. I was sent to school to do a functional behavioral assessment, and I ticked all the boxes, and the frequency of this kid's out of seat behaviors were off the charts compared to another. We did 15 minutes of history, and I could throw those notes out the window because the kid didn't have any history of that before, but the parent, just relocated the family after a divorce. They're in the third school in 2 years. The history really told the story more than the symptoms. And so making sure we understand what's going on below the symptoms. Autism, I think this is where there's a lot of media attention. Autism is a much lower frequency occurrence. The prevalence is much, much lower than ADHD, but the symptoms are much more profound and impairing. And there's a lot of media attention, even on TikTok, about, am I autistic? And so I think a lot of people will think that they may come in seeking medication, or vice versa. They may think they're autistic when in fact they have ADHD. I see it where people want to have autism ruled out when there's really none of the difficulties with joint attention or the perseverative behaviors, and it's just really ADHD symptoms that are so significant that they think that must be something like autism. Sleep. And I would just say, from a PCBH standpoint, we all need to screen for sleep issues. If someone's not getting sufficient number of sleep hours or quality of sleep, they're going to look like they have ADHD. All of you guys went to graduate or medical school. You've pulled an all-nighter, I'm sure, in your time. You've stayed up late, worked on things, burned the candle at both ends. There are times, I am certain, that you've seen the effects of poor sleep on your attention, concentration, and behavior. That I often have a stress-induced ADHD for myself when I'm taking on too many things. But if we're medicating that, we can keep them up and we can keep them alert, but we're missing the forest through the trees. I'm going pretty fast, so please stop me if I'm flying past something we wanted to talk about more. I also don't have a great gauge because I don't know how many folks are peds, so this may be also a little bit of a revisiting of things for a lot of folks. Evidence-based assessment, the gold standard. I'm going to start with the gold standard, not in PCBH. Gold standard is to get a comprehensive developmental history, clinical interviews with parent and child, with some cognitive screen elements, and parent and teacher rating scales. That's the gold standard. It doesn't require neuropsychological or cognitive testing or CPT testing. There are no labs that can test positive for ADHD. Are those things helpful? They can be at times. I will argue that for adults, we might go to the more extreme comprehensive version that includes neuropsychological testing if we're unable to unarchive these other elements that are necessary. Key things that we do that are just a matter of course in primary care is universal screening. So for individuals 4 to 18, we should be doing the pediatric symptom checklist 17. The 17 item exam is as shown validity and reliability. That's it's equitable to the 35 item version. So I would encourage using the 17. Also, making sure that parents complete it. Children and adolescents less so, but children who do self-report measures or that have ADHD tend to be poor performers, poor historians. They tend to see their symptoms as fine, they're everybody else's problems. Whereas the parents recognize that in the context of these social situations. I incorporated the disruptive behavior rating scale here. It's not exactly in the public domain. If you buy a $30 workbook on ADHD, it's a Russell Barkley and Kevin Murphy published this through Guilford. And I don't get a finder's fee. I just share it because I use it. It's simple and it's easy to use. It maps on to the DSM clearly for ADHD. Whereas the Vanderbilts are what are going to be, really encouraged by American Academy of Pediatrics. But the Vanderbilts can also be a little lengthier and cumbersome at times. So I just have this in my back pocket to use pretty easily. And the DBRS, it has 18 questions that are just the first 18 are ADHD questions. There are 26 questions so I didn't have the rest of that on here, but the rest are ODD symptoms. And so these are just good screeners. And you can see if you can look closely that the symptoms cross over. So fidget is unable to sit still on the pediatric symptom checklist, fidgets with hands and feet and squirms in seat. So there's only so many ways to ask some of the same things here. The Vanderbilts have those. They also look at a broader view of psychosocial symptoms. And again, this is the gold standard for pediatrics. So familiarizing yourself with these measures would be very helpful in working with the pediatrician or family medicine physicians that you're working with. It's also in the public domain and easily accessible. For adults, there is a public domain adult self-report symptom checklist. This is extremely prone to confirmation bias. And it's very easy to see the face validity of the items being asked. So if someone comes in motivated and with the belief that they have ADHD, or the belief that they just want medicine, whether they have ADHD or not, which is often a motivator. I don't like to get into motivations and why people are there. I try and meet them where they're at. But looking objectively, this kind of rating isn't necessarily going to help you determine, well, is this really true, or are they just trying to get this to this outcome? The best practice would be to get a comprehensive neurocognitive evaluation. And within that, making sure that there is a very distinct depth of developmental history and an individual's recall of their history. Well, yeah, I did have trouble in school and things like that. Really getting a multi-informant account. I have been on, I've done phone interviews with the parents of a 33-year-old a couple weeks ago. I've had spouses that I've interviewed because they can tell you in 5 minutes if the symptoms are present and how they manage. So there's just limited screeners in the adult world because there's a retrospective bias and a confirmation bias. So I do use this adult screener. I'll also, especially if I don't have access to as many other informants, I'll use the brief rating inventory for executive functions. That's something a lot of clinical and neuropsychologists use preceding their testing. It's a great form. It's not cheap, so I think it's $4 per form. It's easily distributed via electronic means and completed in the cloud, but it's not something like on the pediatric side where we can actually utilize some things that are in the public domain to get where we need to go. Let me just give you an example of a universal screening protocol. So this isn't ADHD specific, but this is how we use the pediatric symptom checklist. So, we administer the PSC 17. This is an old example, but for all 7 and 11 years, that was for a pilot. We do it for all children, 4 to 18. Administer the pediatric symptom checklist, and then it has 3 primary domains. It assesses for externalizing problems, attention problems, and internalizing problems. The weakest of those 3 scales, I believe, is the internalizing problems. It only has 5 items, and like one that really focuses on anxiety. But this is a screener, so we're casting a wide net to make sure nobody slips through the cracks. When we do this for externalizing problems, if those are endorsed, if we have 7 or more of those symptoms endorsed, we'll do a brief history of the disruptive behavior, get parent and teacher Vanderbilts, or disruptive behavior rating scales. We might work on a behavioral goal setting strategy with the parent, and then follow up sometime within the next 30 days. So this is something we implemented when we weren't at capacity with behavioral health consultants. We had a few behavioral health consultants, but a lot of time there were certain days even where we had none. And so we wanted to give the physicians tools that they could use when we weren't there. The setting I'm at now, we're here all the time. So we would be doing a lot of these things on our own. So after administering in the follow-up the Vanderbilts, we would see when those come back, do they have more than 6 or 9 out of 9 symptoms of hyperactive and impulsive symptoms? They have more than 6 of 9 attention problems. And if those are endorsed, we could either initiate a behavior therapy, particularly for the externalizing problems. If it's exclusively inattentive or combined, we might initiate a low-dose stimulant medication trial and work with establishing a 504 plan. For those of you not familiar, a 504 plan is a classroom accommodations plan that's based on Section 504 of the Rehabilitation Act of 1973. That could be a whole other in-service, but field questions if we have inquiries about that too. With attention problems, brief history of inattention. We will look at the Vanderbilt's daily school to home note, something we'll set as like a daily report card, focusing on a target behavior for staying on task, and then a less than 30-day follow-up. I think a lot of times physicians feel like they need to act and either prescribe or not prescribe. We encourage them to schedule a follow-up and do a patient counseling visit for themselves. And then again, assess for 6 out of 9 symptoms of inattention, 6 out of 9 symptoms of inattention with disruptive behavior. And then, again, if it's combined, then we maybe initiate a med trial and start with behavior therapy and 504. If it's only inattention, sometimes we might just start with the low-dose stimulant medication trial. Internalizing, we'll do history, do a coping goal, identify stressors versus more durable anxiety and mood, and then adjustment plan or CBT. But in most cases, we'll just go straight to the behavioral health consultation or refer for outpatient care. When it comes to best practices for treating ADHD, so medication, stimulants, and we'll talk about stimulants versus non-stimulants. Stimulant medication is a well-established treatment for ADHD. Non-stimulants is not. It's recommended but not well-established. Parent management training, behavioral parent training. This is by far the largest main effect. Positive treatment outcomes are from parent training compared to the other behavioral interventions. Classroom behavior management, behavioral peers, summer treatment programs, essentially, and organizational skills training. They share some common qualities that I'll go over. And these are best practices and out in the wild, not necessarily in primary care. So we need to be able to adapt and make these effective in the primary care setting, because that's where the kids are. Some of the things that they share, though, are environmental control. There's a focus on empowering adults to engage in some of the environmental control elements, structure, routines, setting expectations and limits. Contingency management is a core of any behavioral therapy. So not just focusing on providing positive or reinforcement for behaviors that are observed, but also antecedent control. What can we do to set up positive contingencies so that the individual is more likely to produce the behavior that we're looking for versus needing correction, reinforcement, or redirection. So not effective for treating ADHD. Fidget spinners have not solved our problem yet. So I'm sorry to say. They may, in the very short term, reduce motor activity, but over time they tend to be more interfering than anything. Physical activity or exercise, not effective as a treatment. Although a lot of studies have shown the benefits of that for children with ADHD, especially if they get pretty intense exercise early in the morning. That's something where I think the jury's still out a little bit on that. Elimination diets, you can restrict gluten, casein, Bulgarian lamb cheese, whatever it is that you think is going to make it's not going to make a symptom difference. It might make a healthier child. If you load your child up with 4 Voodoo Donuts and a Mountain Dew, their behavior is going to be affected, as would mine and anybody else's. But an elimination diet is not creating a treatment effect. Occupational therapy, play therapy, cognitive behavioral therapy, and insight-oriented therapies, not proven to be effective. I know, it's crazy. CBT is the answer to everything. It's the answer to all our hopes, dreams, and prayers. But you know what? It's answering the wrong question for children with ADHD. We're not changing maladaptive thoughts. We're harnessing thoughts and actions in a different way for behavior therapy. Yeah, you'll see in primary care a lot of kids who get occupational therapy early on because maybe it's pre-diagnosis or they don't know what else to do, but there are a lot of little tricks from occupational therapy, whether it's having a wobble chair or having fidget spinners and doing little quick tricks, but those don't tend to bear out as treatment options that are effective over time. With medicines, these have been around a long time. Methylphenidate is something that was utilized quite a bit in the 50s even. The main effective medications for ADHD are stimulant class medications. So why would I give a hyperactive and impulsive person a stimulant? And the thing there is we're stimulating the inhibitory centers of the brain. And so those fall upon 2 subclasses, methylphenidate compounds and amphetamine salts. Non-stimulant medications sound really good because the term stimulant has this association with illicit substances, substance abuse. Stimulant medicines, when properly diagnosed, have not produced any kind of addictive qualities or problems with needing weaning or withdrawal or anything like that. Non-stimulant medications, much higher risk, much lower effect, much more heavy on one's system. I'll go into those a little bit more. The main ones we often see are the norepinephrine reuptake inhibitors, the Strattera, and we're seeing more of the alpha-2 agonists. So the clonidine, guanfacine, Intuniv, Capve, and those I think we'll see more often when someone has a stimulant, but they're displaying a lot of aggressive behaviors and the physician wants to try and dampen the drive to keep them from being, their own worst enemy and getting in trouble and hurting people and things like that. But it's not a first line medication. So, as much as we've learned, we still don't know a lot. It's a simple medicine, and methylphenidates and amphetamine salts, they do the same thing. What they do is they flood the synaptic cleft full of dopamine and norepinephrine, and increase the chances for uptake. So we're not sure if we're having insufficient dopamine or we're having reuptake of the dopamine from the initiation site. So what this does, it just floods the synaptic cleft, increases the opportunity for neurotransmission. These are some of the ones you'll see most often. I've got little stars on these because those are the only ones so far that are approved for kids ages 3 to 6. All the others, from an FDA standpoint, require that it to be above age 6 and 60 pounds or greater. Now, if you're working with a child psychiatrist, they're gonna make clinical judgments and know how to be conservative with this. But your everyday pediatrician probably will not want to do that. So you're probably familiar with some of these names. There are new ones out too that, there's Kelbury and things like that, but the best evidence supports the initiation of a short-acting low-dose stimulant and increasing it to a level of therapeutic effectiveness over time and without any adjustments within the first 30 days. Side effects are common appetite suppression, anxiety, irritability, difficulty sleeping. The one that tends to persist is the appetite suppression. Research has shown that kids will get the same amount of calories throughout the day, just at different times. So during peak dosage, school-age kids often eat lunch at between 10:30 and 11:30, which would be peak dose of these medicines, writing into their 504 plan for them to loop back and visit the nurse at 1:30 to get a Cliff Bar or a muscle milk or something just to get some protein in them, or Greek yogurt is a good strategy to keep them getting calories in their system. So non-stimulants, I'm going to move quickly because I realized from a time standpoint we've got further to go. Strattera and was designed to be the answer to Prozac when it went when it's I forgot what you call it, not the trademark, when its patent was released and it could go to generic. It failed the trials, but people reported, hey, I can think clearly, I can focus more. So they relabeled it as an ADHD medicine. It has not done well unless people really had more atypical presentations. As I mentioned with the alpha-2 agonists, they're more for managing aggressive behaviors associated with ADHD. Recent studies have shown some benefits from CAPV, which is a longer acting version of Intuniv on attention. Black box warnings, what you need to know, because people will say, oh, I can't do that because the black box warnings. So the black box warnings for the stimulants were due to a Canadian announcement that was of sudden death. And in those cases, there were no cases that had sudden death without a prior heart condition when they looked at the cases. So there was no evidence to suggest that the medicine alone contributed to that. What it did tell us is that we need to make sure that we're ruling out, any kind of physical or congenital heart defects before we proceed. So for a healthy child, there shouldn't be any problems with starting a low dose medication. With Strattera, the black box warnings, again, the studies were for people who are depressed and they reported suicidal ideation. So I think they got asked about their depression. They said, yes, and I feel suicidal. And so when there were no instances of suicidal behavior or completion in those studies, but they still had to have a black box. All right. These are some scales that also are included in that workbook that I mentioned. There's a side effects rating scale that can be really helpful to look at to get parents to monitor with ADHD medications. When they're prescribed, oftentimes people will experience side effects within the first week, but with continued consistent use, I should say, they tend to subside, with the exception of the appetite suppression. We call those nuisance side effects, not because they're only a nuisance. They are intrusive, but they're not long lasting. So we got to let the body accommodate. Most physicians will prescribe a dose that's subtherapeutic, where they don't see a therapeutic benefit, in order for one's body to accommodate, and then they ramp it up to be able to get to a therapeutic level. The school situations questionnaire and the home situations questionnaire. I like these because, unlike the never, sometimes, often, always, this gives us 9 points of variation, and it has the face validity of seeing change when you're monitoring a response to an intervention. You can see that change without a statistical program or anything like that. And I find that when I start talking about T-scores and standard deviations, I see my pediatrician's eyes roll back in his head and go, "Oh, just tell me what I'm supposed to do." This gives them a tool that they can easily use. I can use. We can share this language, and the parents can engage more in the feedback too with a data-driven approach. So now we're in the home stretch here. We're talking about parent management training. With parent management training, there are two core components of any parent management, behaviorally focused parent management training. First, focusing on child-directed interaction, focusing on how to give our attention, how to take our attention away. We give our attention to the behaviors we want to see more of. We take our attention away from the ones we want to extinguish. So that's that child-directed attention where we're following and engaging in pleasant activities, doing things that are focused on attachment. And then we go to parent-directed activities. In the second phase, where we're teaching effective commands, setting target behavioral goals. And those goals need to be very specific on promoting a positive behavior versus extinguishing a negative behavior. What I often do in my treatment programs is I'll focus on high frequency behavioral demands. So these are not necessarily like not hitting my sister, but it's what I need to do on a daily basis to get better outcomes. So for instance, one of the first ones we'll introduce is the target behavior of showing I'm paying attention. Every kid I interact with knows how to show they're paying attention. If I ask them the question, if you're showing you're paying attention, what should you be doing with your eyes? Oh yeah, that's right. Yeah, looking at me. Okay, you're looking at my elbow? No, no. Where you should be looking at? My eyes. Yeah, face-to-face eye contact. Where should your body be? Walking away, moving closer, moving closer. Right. Yeah. Should it be creepy close? Nope. Closer, but not creepy close. So I will get into painful details because my kids will love to get creepy close to show me, oh yeah, look, I'm getting closer. And I don't want to reinforce that. And then I'll say, okay, now I usually do something with my head when I'm listening, when I'm showing I'm paying attention. If I'm showing you I'm paying attention, what am I doing here? Nodding. Yep. Okay. Face-to-face eye contact, moving closer, but not creepy close, and nod my head. And then we'll introduce that as a target behavior. We'll create rewards for performance on a daily basis. We'll set the beginning of the day with all right, remember we're working on this. And then 30 seconds after that, say, hey, Malcolm, they turn around. Look, I see your eye contact. Way to go. Nice job. 1,000 times throughout the day, giving that behavior specific praise. And at the end of the day, how'd you do? 0 means you didn't do it. 1 means you did it, but I had to help you. 2 means most of the time you did it on your own. And then we reward them with points, token, sticker, whatever it is that you're choosing as your reinforcer. And we do that until we master a target behavior. Then we move to a new target behavior. So many token systems you'll see are 3 or 4 behaviors that we're working on at a time. These kids have attention problems. These parents have a hard time giving their reinforcement to 3 or 4 things at a given time. We're going to focus on a really narrow aim at reinforcing a single target, building competency and overlearning, and then we'll move and graduate and chain that behavior to another. So I might move from showing I'm paying attention to sounding like I'm paying attention, to following instructions the first time, to managing personal space or turn taking or using an inside voice. Or these are all things that have a high frequency demand for these kiddos. And if they're getting positive feedback at home and at school for doing them, their quality of life is going to be significantly increased. So with parent management training, mentioned this child directed and parent directed. I'll just give you a quick case run through, and then hopefully we can have 2 minutes to wrap up. So if John came in to establish care with the pediatrician, he's already diagnosed. He was diagnosed at age 7. Has been on methylphenidate with inconsistent access to his medical provider. His mom reported that he's been oppositional and not following instructions. She describes his behavior as out of control, notes he's having trouble at school. He gets no services at school and grades are failing. We might do a 30-minute diagnostic review since we're not starting from scratch, just making sure that we see what the history, reported history tells us. Rule out other kinds of influences. We create, we outline interventions, started by letting them know how we're going to use the Vanderbilts and get home and school versions for those. And we might initiate the first module of a PMT protocol. With the pediatrician, they'll complete the well check and refill the current stimulant based on our validation of the parent reports. Then we'll move on to having a follow-up in 2 weeks. We'll inquire about how he's responding to the medicine. We'll go to PMT module 2, and this is where we might introduce a special time where there's a child-directed interaction where we do a play-based activity where we teach the parent to attend or to disengage on desired versus undesired behaviors. We will communicate the progress and medication response, perhaps using one of those med monitoring scales that we looked at before. Then another week and a half, 2 weeks, we'll do module 3. Again, review Vanderbilt's. And here we're seeing afternoon impairments with increasingly hyperactive, impulsive, and sometimes aggressive behaviors. So we consult with the pediatrician. We give some recommendations for classroom accommodations that might be helpful. Pediatrician also saw the patient for a walk-in medication adjustment since they're there seeing us in the primary care setting. They noted the weight gain, continued progress with weight and height. Titrated the methylphenidate and moved it up to 54 milligrams instead of 36. So with follow-up, we might get a social worker that calls, or one of our students that might call within a week to check on the response to meds. So we didn't just increase the dose, but also had a check-in to see what are we seeing, not waiting till the next return visit to make any adjustments. We see the patient and family every 2 weeks, modules 4, 5, and 6, maybe focusing on introducing those behavioral goal, effective commands, behavioral goals, and then working towards some corrective or disciplinary strategies. The pediatrician continues to review results of our behavioral measures that we're monitoring each time, and notes any side effects, refills prescription, and based on the feedback that the behavioral health clinician and the family are providing. So we'll continue this. In this case, I'm outlining up to 7 and 8. We may not have that many opportunities, and I think that sometimes we can get pretty far with 3 or 4 sessions, getting some of those front end parent-directed activities in place. But in these latter sessions, maybe focusing on generalizing some of the things that parents have practiced to help them advocate for their child in school. The pediatrician will, again, work in either co-visits or with timed stacked visits so that we can provide care without them going to multiple providers in different locations. And given this kiddo's aggressive oppositional behaviors, he's going to initiate a 1 milligram dose of Intuniv, guanfacine ER. Continue to follow up. Not seeing any medication side effects. We continue to consult with the pediatrician, and then we increase to 2 milligrams daily for the guanfacine, and a 30-day medication follow-up. So this is an example of a very, very quick run through of a PCBH type of workflow. And I think that for those of you who work with pediatricians, there is a type, and I find them incredibly collaborative, fun. They maintain their their playfulness of childhood. It's so fulfilling to be able to work with a pediatrician. Not that family medicine is not. I enjoy my family medicine colleagues, especially the ones that gravitate towards treating the children. But it's a very enriched experience to be able to do these things together. One of the pediatricians I work with here asked me to come in before he ever makes a warm hand. He just wants to introduce us before he ever gets started with a new patient. And I value that a lot. Wanted to share with you some other things that I often recommend to families that they can look up and utilize for themselves, some self-help resources. This is an area that I live in a lot and dive deeply into. So I know that when I'm working with other clinical populations, I benefit a great deal when people recommend the things that they've read and reviewed. These are all really good evidence-based resources that you can refer to. So I am 2 minutes over, and I apologize for not keeping it under the hour. I can stick around for a little while if people have questions, but I also understand the clinic demands that you guys have. So, Rachel, I don't know what your standard is for doing this. So just
No, I was just gonna say thank you so much for your time. I wasn't bothered by you going over, so I think it was very appreciated. If there's anyone who has any questions, I know there were a few in the chat. If maybe you just wanted to look and see if there were any that you wanted to answer, it's being recorded, so we can always send it out and people can see. But if there's anyone who stuck around who maybe has a question, we can take a few minutes to do that before we let everyone go.
Okay, I will. I've included my email here. I am more than happy to share resources with you, answer questions. Just be on the speed dial if you ever need anything. So please don't hesitate to reach out. Let's see, I'm going through the questions here. Some thoughts about the common combination of ADHD and autism now. I will say that with ADHD and autism, historically, the DSM said that they were mutually exclusive, and that's no longer the common belief. I've certainly seen kids with both. I will say that many times with a true autism diagnosis, and if there's intellectual delay, that ADHD really, I don't I don't know how often the ADHD diagnosis has been helpful because if there's a global cognitive deficit, you're going to see attention related differences compared to typical populations. I guess the only time where that could be beneficial is if there was a medication to be considered. And again, I don't know that that's always the helpful outcome to be looking for. I'm a behaviorist. I don't prescribe. I'm biased that I think we can do a whole lot without medicine. But I've also seen kids that, without medicine, their lives are just not nearly as positive as they could be. Let's see. With adults, encountering more young adults seeking testing whose parents don't speak English, recognizing the focus on children today. Curious whether anyone knows of any standardized collateral report measures in other languages, Spanish in particular. I typically use the bars for adults. So this is for adults. The behavior rating inventory of executive functions, the brief, has adult forms and it has um, other providers or the other informants, and that is in Spanish. So again, that's one that's not open access and within the public domain, but you can get that through PAR Incorporated, and it's very easy to use. It's a system that you can distribute with the individual's email, and anyone that needs to complete it via email, and it's a secure cloud-based format, and it has its own scoring built in, so you're not having to learn how to score. You just know the parameters you want to put in there. But that might be an option for you in Spanish. Gosh, just made one thing that's very hard even harder, and Spanish than this. More about Spanish measures. For children, the pediatric symptom checklist is in Spanish, the DBRS is in Spanish, the Vanderbilts are in Spanish, and the behavior assessment system for children, third edition, is something I use in outpatient all the time, and that's in Spanish. And that's a much more in-depth, thorough evaluation form. I'm not 100% sure, but pretty confident that the ACEBA, or the child behavior checklist, that's sort of the commensurate instrument to the BASC. I believe that's in Spanish too. I don't know how it wouldn't be. It's in so many studies. Okay. So why do I recommend neurocognitive testing for adults and not necessarily children? Well, first of all, that's not my specific recommendation. That's what has been established as a evidence-based assessment. Because with children, the things that we find out in a neurocognitive test, we can find out clinically without doing that much invasive testing, and it's very, very costly too. So neurocognitive testing is seldom covered by insurances. It falls between medical necessity and educational needs. So in a school setting, they're not going to test for ADHD because it's not an educational problem. It's a medical problem. And in insurances view it as an educational need. And so neither really cover it. And so to get a neuropsych testing, most of them start around $3,000 now in the private setting, and they take time both to get in and to complete. When I can get enough clinical information with a good history and rating scale, functional assessment that way, that I can get them to the point of treatment faster, and usually with limited differences. Now, neurocognitive testing surely gives you very specific information to see to what degree is working memory implicated versus processing speed. How do related to cognitively shifting between one demand and another. It can be very helpful. So I'm not saying it's not helpful. It's just not necessary for a diagnostic conceptualization. Now, with adults, when I say it's encouraged, is because we don't have the ability to access multi-informants and to see kind of how it's emerging in a functional setting with history over time, like we do with kids. We have more of a controlled environment for the assessment. And so just to rule out retrospective bias and confirmation bias, that testing is a functional performance-based assessment. So that's why I put that in. Tolerance. The UMass webinar on adult ADHD and PC yesterday, they said that the vast majority of studies on the efficacy of stimulants in adults only look out 12 weeks. Do we know if the research is more longitudinal in children and adolescents? Yeah, there is more longitudinal data for children, and so I think that tolerance uh, is sort of a term that we kind of think about in a substance use disorder framework. I think what we might see is lack of continued benefit. So we don't see tolerance like an addictive quality where we need to have a certain level, but rather that there's maybe diminishing returns for increasing doses at a certain point. But yeah, it's ideally, when we're focusing on medication management, we always want to go with the least amount necessary to get the result that we need. But yeah, it's a great question. I don't have the studies to top of mind to share with you though. Will you be sending out the recording slides? That's a Hannah question. She got
Yes,
that.
we will be. I think you covered all of the major questions. I think some of the other ones were just logistics, but Dr.
Okay.
Curtis, thank you so much for your time. This is really helpful, and I'm sure I'll be showing the recording to colleagues as well.
Well, I appreciate the opportunity to share. It's a good group, and I'm excited to be a part of it.
Yes, thank you so much, everyone. Thank you for coming. Thank you for staying over a little bit, and we'll see you next time.